Hi, everyone. Welcome to the next part of the lecture that is in Chapter 5. We ended our lecture face-to-face in class with gallbladder disease. So the next slide in Chapter 5 is pancreatitis, okay? So again, these videos are only 5 minutes, so I'm going to do small chunks here. So pancreatitis is an inflammation of the pancreas. So remember that pancreas is very important for um, producing and releasing those digestive enzymes that are required for all three macronutrients. And when the pancreas is inflamed, it blocks some of those enzymes from being released. So we'll typically see some fat malabsorption, also called steatorrhea. And the typical treatment for this is for the patient to be NPO, so nothing by mouth for a few days, and then eventually progress to a low-fat diet. And we want to do a low-fat diet because that's going to decrease the amount of enzymes that the pancreas needs to produce. Symptoms of pancreatitis: the tender abdomen, nausea, vomiting, fever, increased pulse. The most common cause is gallstones blocking that pancreatic duct, but we also see alcohol abuse, injury, infection, and medications that cause pancreatitis. The next section is renal disease, and you all know from medical terminology that renal means kidney disease or relating to the kidneys. We have CRF, or chronic renal failure. You might also see that as ESRD, which I have right here highlighted, end-stage renal disease. CRF is not reversible, and we'll contrast that to ARF, which is acute renal failure. Acute renal failure is reversible, and it's often caused by shock, burn, infection, injuries, medications. So someone may temporarily be put on dialysis with ARF, and then they'll regain function of their kidneys. With CRF, they need to have dialysis in order to keep living, and they can do two types, either hemodialysis or peritoneal dialysis. What we have here, hemodialysis, that's the type that most of you are probably familiar with, where the patient is going to a clinic and having treatments done every 2 or 3 days. Peritoneal dialysis is done by the patient themselves at home using their own stomach lining as the abdominal cavity as the dialysate. So with peritoneal dialysis, fluid is introduced via catheter into the abdominal cavity, and then the body gets rid of that, and the patient can do all of this at home. So this is for a motivated, young, healthier patient. Hemodialysis, the person would go there and go to the clinic, and they would be hooked up to a dialysis machine, which is what most of us are familiar with. So remember, the function of the kidneys is to form urine, produce hormones, form vitamin D. So if the kidneys aren't working properly, then we can see some significant problems in overall health. Oftentimes, someone with CRF or ESRD is low iron status as well, because one of the hormones that the kidney produces is erythropoietin, which is responsible for the production of red blood cells. For both types of dialysis, what's happening is that the urea, which is a byproduct of protein metabolism, is separated from blood, and it's removes the waste and the fluid. So because urea is a byproduct of protein metabolism, our protein need calculations are going to be slightly different for these folks. As you can see in the section in your book, renal diet is rather complex. We may see restrictions in protein, sodium, potassium, phosphorus, and fluids. Typically, we'll see a protein restriction if the person is not on hemodialysis. So recall that the RDA for protein is 0.8 grams per kilogram of body weight. For someone with kidney disease that is not on dialysis, that protein needs would be